Hey guys, Dr. Warwick is a preventive cardiologist who has been posting on Instagram now for a while. He's been tremendously successful spreading the word about preventative cardiology and things we can do to avoid coming to people like me and him in the ER and the cath lab, right? Yeah, and from what I understand, you've experienced a lot of patients who had early MIs, and that has been, I think, an inspiration point for you to launch this platform to really educate people how to not get sick. Am I right about that, Dirk?
That's what drove me to post.
Yeah.
So, as we've connected and become friends, I shared that my division chief of all people, just with my communication style, thought that that I'd be a good fit with social media. But I actually decided to post because every single week I met a new family that had someone die of an unexpected event in their 40s or 50s. And so I thought, just as a user of social media, I had to start getting the message out there.
That's something else, and your page is incredible. I'm looking at it right now, and one year you have done so incredibly well. Keep up the great work, and thank you for joining me today at 5 o'clock. So you posted. We did a collaboration today about this issue, and the question is, you asked the question as to what is the most common cause of MIs in women. How do people do? And what is the answer, Dr. Warwick?
They did pretty well. And I think it was a perfect setup for our live session today because most people got it correct. About 60% answered correctly that coronary artery disease, or plaque, the buildup of plaque inside that coronary artery, that's the #1 cause of a heart attack in all age groups of women. But also the #2 answer was SCAD, or coronary artery dissection, that can happen spontaneously. That was the #2 answer, and I think that highlights the increasing recognition that we need for that, which you've been doing just here recently on social media, and something that we're excited about to talk about today.
Yeah, so let's talk a bit about that maybe, and what's your understanding of that?
Yeah, so my preventive practice focuses on the #1 answer, the coronary artery disease, and how a plaque builds up over time. And it's really astonishing how I'll work with all these families, and you will check young individuals with fairly lean build, they eat relatively healthy, they exercise, and they'll have sky-high LDL cholesterol, they'll have high Lp(a), they'll have high triglycerides, they'll even have metabolic liver disease at a young your fatty liver. And so we have had increasing recognition about coronary artery disease, even if it's under-recognized that it happens so young. At the same time, it's been under-recognized that the coronary arteries themselves can scarily spontaneously fail. And when you think about it, I like to teach through analogies, so I use analogies all the time in clinic, and I often think about the heart as like the engine for the body. And so we think all the time we're worried about the heart muscle. That's like the metal part of your engine, the metal casing. And those parts are really durable. So in many cases, your heart muscle is durable. But the coronary artery is just this tiny hose, this essential for life tiny hose. And the casing of that hose can fail. And if that happens, you can have either the blood vessel wall itself fail, or it can split, and then blood can get in there and collapse the inside of the coronary artery down. And so that's SCAD. And the scary thing about that is every single day in clinic, I meet a new patient with hypermobility, connective tissue disorder, some kind of vascular stretchy concern. And when you think about the shear stress, the mechanism that might be related to this, where you have this tiny coronary plunked into this massive aorta, and how it gets that shear stress, eventually under normal mechanical load, it can fail. And so for young women, so women typically in many series age 43 to 54, it's disproportionately affecting them. And something you've done a wonderful job, of course, speaking to, the stress test of pregnancy. So that's the scary thing, is if someone is listening to this live session and they have hypermobility, an inflammatory condition, have ever been pregnant, have tested or not tested LDL, Lp(a), hsCRP, blood sugar, have uncontrolled blood pressure, or go through menopause, they're all at under-recognized risk. And that might cover just about everyone that's listening to this session.
Yeah, thank you, Dr. Weyrauch. There's some questions coming in already, but let's try to save some of these for later on. And can you see the questions coming up in your feed?
Ooh, no, I'll have to get those up. This is for anyone watching. This is my first live session, so thanks for the opportunity.
Yeah. So the question is: any advice for someone with sounds like Prince Metal angina, even with medication? I'm truly symptomatic, not as bad. However, I get flare-ups. Prince Metal angina. I think this person is asking about Prince Metal angina.
Yeah, so if we're worried about coronary artery spasm, the hard part is if you think about a part of your body that's already been damaged, it's not fair, but it is something that if we recognize that blood vessel is damaged, we know that we want to prevent any triggers. And it's very difficult when I tell my patients, hey, stress is bad for you, so don't be stressed. Then they just become stressed about the stress. But there are some really strong signals regarding the fact that your body can surge itself with stress hormones with the simple trigger of emotional stress. Yeah. And so the more that I can get data working with patients and lead to what is related to those flares, right? Giving general education, not able to speak to anyone's individual health situation, you can track down what might be related. Do they have an inflammatory component that hasn't been checked? Have they had blood pressure that's adequately under control? Have they had adequate sleep and they have appropriate restorative sleep? And then have they proactively been able to manage and mitigate and prevent stressors? So often I find that although I'm a preventive cardiologist and I'm very proud of the expertise that I've cultivated through that, I'm often recommending dietitians for my metabolic health patients and therapists for my cardiology patients. So really, even if we can't fix the fact that artery can be prone to spasm, if we can address what's triggering it, we can prevent it. And so it just always comes back to prevention.
Yeah, it really does. So let's talk about statins, for example. A lot of women are on statins. Are they at some unique risk because of this?
That is one of the most common questions. I'm so glad that we have the chance to talk about that today because actually they're at unique benefit. So when we think about statins, the statin class of medicines basically addresses the simple fact that if someone has high cholesterol, I cite in clinic 80%, obviously it varies, but 80% of their cholesterol level is genetic. And so it's not coming from build, if we have extra body fat, from their diet, extra saturated fat. If they're not exercising, it's mostly genetic. And their liver's making too much, and the little protein that's supposed to clear it from their blood isn't clearing it as fast as the liver makes it. Yeah. So if you can take a safe, effective medicine that just drops that liver production, boom, you still have plenty for what your body needs. The cells make their own cholesterol anyway. They actually make so much, they have a mechanism to export it. It's just like people have their own individual bank account of money, but there's money circulating in society. So there's still plenty of cholesterol left over for hormones and all sorts of uses. You're just dropping that serum cholesterol level down. And so I would say what we do know is not any unique risk for statins with women. We know the unique risk that women have from under-recognized and under-treated heart disease.
Yeah.
So over and over again, as I come back to this, as I address it in clinic, as I read through the literature, as I go to these conferences, if you join the preventive cardiologists at our conferences, we're not talking about, oh no, here's the side effect from statins. We're talking about, look how undertreated women are. And here we have this safe, effective, well-studied, cheap medicine that could plummet an LDL level. And then we have misinformation often online that leads people to have understandable but regrettable confusion or doubt regarding the safety of a treatment that could save their life. So the unexpected risk for statins with women is in not taking them.
That's something else, because I think that, people think, oh, I'm young. I'm young. Yeah, my cholesterol's high. I've got pure hypercholesterol. I don't need to take it because I'm young and I'm healthy and I've got no other risk factors. I don't smoke. I'm a marathon runner, and yet we've seen, you and I have both seen marathoners dropping dead of a heart attack. Speaking of hormones, can you talk to us about hormonal changes in women, and especially in regards to post-menopausal women where there are hormonal changes, and maybe even touch on HRT and hormone replacement therapy and how that influences and modifies risk?
So I think that's a fascinating question, and that's reflected by that being perhaps the #1 most requested topic that I receive as I keep track of them through all the comments on posts. And that's actually the question that inspired me to work on a women's health series. And so with that, the concern is that women might have some cardioprotective benefits from the hormone balance. So oftentimes I'll tell family members that it's an early heart event if it's younger than 55 for men or 60 for women, although really all of them could or should be prevented before like age 85. So if women go through menopause, then the concern would be that they might lose the hormone balance that protects them and now be put at risk. And then if you add to that a lot of the social factors that lead to women being undertreated, if symptoms are dismissed as anxiety, if symptoms are under-tested, if, basically they're not recognized, women then become high risk and it's missed. So the educational point on this topic is that unfortunately, as in many places, women's health is not well studied. So I like to give evidence-based guidance, and I'll be the first person to say either I don't know or we don't know. And so I don't think we've fully clarified any cardioprotective benefit for hormone therapy. So it's not indicated to do hormone therapy to check against any increased heart risk from menopause. But for two populations, it's really important to talk about with your doctor. People that go through early menopause. If you go through early menopause, now you could be at higher risk for a heart event. That doesn't mean that you necessarily need hormone replacement therapy, but it does mean you should have a conversation with your team and check for any heart conditions that are missed. Because the menopause or early menopause, I wouldn't think about that as causing a heart attack. But if it takes away a blanket of protection, now you might be at more risk for what we know causes heart attack. So if you're a woman that's going through menopause and you have an inflammatory condition or autoimmune condition, and that hasn't been addressed, and that heart attack risk hasn't been addressed, oh no, that's a miss. That's something that we can act on and protect and prevent. So for women that go through early menopause, a specific cardiology preventive visit is indicated. And then actually, unfortunately, there's an interesting correlation with more vasomotor symptoms, so like the hot flashes, night sweats, that and heart risk with menopause. So although this may not add a lot of relaxation to maybe some people that are listening or receive this message, it's one thing to have a risk factor, but it's another thing to have had the chance to have acted on it, to have missed it. So for people that go through early menopause or for people that have increased vasomotor symptoms, those are two patient populations where it's recommended to get extra special heart care.
Derek, are you saying that there may be an association between symptomatic menopause and the risk for heart attacks?
Yeah, as a buddy of mine in college who's now a successful internal medicine physician like to say, correlation isn't causation. And
That's
we
correct.
say that all the time in medicine.
Right.
But that has been one takeaway, both clinically and with a little bit of literature that we've seen. But I think the main problem is just that we need a lot more of this to be studied. When we think about preventive cardiology, it's only just become like a formative subspecialty within cardiology broadly. And so I think as we advance the field, we'll be able to advance the science about this really important issue.
That is fascinating. I think we and I should need to talk more about that, because I get asked that all the time. I get asked that not all the time, but I get asked that sometimes. And the question is, oh my God, I'm having these symptoms. I've had these symptoms for the past year. Am I at risk for anything? And I don't know the data exists, like you said, but it may be a correlation, but can't say a causation, right? So great point.
Right.
Thank you for bringing that up. All right. And you know, this other issue comes up, and the issue is, the issue really is the risk between heart disease and dementia, cardiovascular risks and dementia. What is known about this?
So I love this question because it's near and dear to my like related family members that I cover. And this comes up all the time. Every single day, people ask me about one of two things, either dementia related to preventive health or dementia related to the treatments. Like there's a common unfortunate misinformation line about some risk for statins and dementia. And so an analogy I like to use would be that I'm a heart attack prevention doctor. So a heart attack is a sudden blockage or problem with the coronaries that blocks blood flow. But a lot of my families are affected by congestive heart failure and ischemic cardiomyopathy. So then for people, that would be the slow, progressive, almost like kind of strangulating loss of blood flow to the coronaries, not a sudden closure where it's blocked off, but just that slow, indolent loss of blood flow to the tissue, kind of slowly killing it over time, which is stark to think about. So if you think about a heart attack being a sudden problem, and then congestive heart failure being a long-term failure, I think about a stroke being a sudden brain problem, and dementia being a long-term failure of the brain. And so how do we protect the heart from congestive heart failure? Well, we make life easier on it by protecting it from blood pressure and by preserving blood flow, by blocking plaque. Well, how can we protect the brain? Well, we can make life easier on it by protecting it from blood flow, from toxic compounds like from cigarette smoke, and by protecting blood flow by stopping blocking plaque. And so with that, I talk about my practice as a preventive cardiologist basically being analogous to being a preventive neurologist. So you can protect against dementia through protecting blood flow to the brain and preserving it. And even there's a fascinating study that had looked at all the different factors associated with dementia, and 45% of cases of dementia they found could be controlled or just completely prevented by controlling 14 risk factors, and one of those was LDL cholesterol. So then for my patients that are worried about dementia, I'll tell them if they're worried about dementia and then any association with statins and dementia, I say the only association between statins and dementia is that statins allow you to live long enough to get dementia. And typically that they might laugh and now they can understand and agree, oh, great, okay, I get it. We want to preserve blood flow to the brain, and that'll preserve its function.
You know, this is not for now. This is a second IG Live for sure. The correlation between, I love that association, by the way, you know, the thing between heart attacks and failure versus strokes, dementia. I think it's, you know, I never really thought of it that way, but I love that. It's very good. So thank you for that information. So good. So good. So anyhow, listen, we are running short on time. I do want to ask you one more question. And the question really is to talk about some of the unique factors, you know, and the correlation between autoimmune diseases and sudden cardiac death. Can you just touch on that for us, if you don't mind?
Yeah, so there's a big study that came out, or at least was disseminated in May to the public, and it looked at the sudden death risk for women with inflammatory or autoimmune conditions. So you could think of like rheumatoid arthritis, anything that would cause chronic inflammation or autoimmune related damage in the body, sclerotic conditions, so systemic sclerosis, things like that. And they found not only was there a shockingly high risk, but it disproportionately affected women to the point where women were 3 times higher than men.
Is that right?
Suddenly. Yeah, to die suddenly. And this was in a massive, well-controlled, well-done study looking at hundreds of thousands of deaths. And so women were at least 3 times more likely to die of a sudden heart event than men were. if they had a chronic inflammatory condition like the rheumatoid arthritis or systemic sclerosis, anything like that. And it's just incredibly underrecognized. And so that's where, when I talk with families, they'll ask all the time about different things that they've seen or heard online. But one thing I'll tell them is if I ever encounter someone that says, oh, cholesterol's not bad for you, I'll say, no. Cholesterol is a known risk factor for heart attack. We have 70 years of data knowing about this. It's like 2 + 2 is 4. Wear your seatbelt, and LDL cholesterol causes heart attacks. But it's not the only thing. And I often make a joking reference to Australia, saying that cholesterol is not bad for you because inflammation can cause a heart attack is like telling an Australian, like, great white sharks aren't bad for you. My buddy got attacked by a crocodile. It's like, no, if you're in Australia, there's crocodiles, there's bull sharks, tiger sharks, there's box jellyfish, there's like every kind of spider, snake. Yeah, just it's a minefield out there. And heart attack risk is the same thing. LDL or ApoB, triglyceride, hsCRP, blood sugar, blood pressure, they can all get you. But in a fantastic New England Journal of Medicine trial where they looked at LDL, Lp(a), and hsCRP as the proxy for inflammation, they found basically a 33% increased risk of heart attack for long-term LDL, a 30% increased risk for Lp(a), and even up to like a 70% increased risk for inflammation.
No kidding.
Yeah, and then it got worse when they were combined, which makes complete sense. You have this inflamed, damaged coronary artery that then has LDL deposition, and they never had Lp(a) checked, and then boom, heart attack in their 40s. So controlling inflammation is absolutely essential and under-recognized in heart attack prevention, even if it doesn't mean that we can dismiss those other known things like LDL and Lp(a).
Wow. This is incredible, educational for me, and I'm sure for our audience too. So thank you so much. We are coming up on almost a half an hour, double the amount of time I take on these IG Lives. And it's been absolutely fantastic to hear from you, to learn from you. And I'm sure our audience is the same way. Let's pick this conversation up. I do want to wrap it up right now. Folks, thank you so much for joining us. And Dr. Derek Weyrauch, I think you are a growing star. Not a growing star, you're a star on Instagram. And folks, if you don't follow him, you got to do it. Get on his website and follow this man. He's got some great information for you. Derek, my friend, thank you so much. Let's do it again and dig into some of these great issues we brought up today and really focus in on some of the ways we can help people's lives.
Pleasure is all mine. Thanks for your friendship and thanks for your mentorship on here. I really appreciate the opportunity.
You bet. Folks, thanks so much for joining me today on Friday, my 5 o'clock Q&A session with Dr. Derek Weyrauch. So long for now.